right, good morning, everybody. Good morning, St. Luke's. Thank you, Dr. Seward, for giving me this opportunity to introduce my colleague and friend, Dr. Robert Lookstein. Just a quick housekeeping item, first of all, before we talk about grand rounds. On February the 27th, there'll be no grand rounds, so please put that in your diary. So it's a great honor to introduce Dr. Robert Lookstein. I'll just start off with describing his titles, and then you get an idea of the scope and the breadth of the work that he has to do in the Mount Sinai Health System as an academic, an educator, and as an innovator. He's Professor of Radiology and Surgery at the Icahn School of Medicine. He's Vice Chair of Interventional Services, Department of Radiology, Executive Vice Chairman of Department of Diagnostic, Molecular, and Interventional Radiology, and is Professor of the Graduate School of Biomedical Sciences at Mount Sinai Institute of Technology and the Entrepreneurship Program. So I just met Rob and I said, how do you do all this? And he shook his head. So he was a resident in radiology at Mount Sinai, did a fellowship in vascular interventional radiology. When he had some spare time, did a master's in science and healthcare delivery at Sinai, and has been a member of faculty and has ascended the ranks since 2002 at Sinai. So his research focus is on vascular medicine and endovascular therapy for peripheral vascular disease, both arterial and venous, and published on endovascular repair of AAAs, visceral artery aneurysms, and endovascular treatment of PVD. And his clinical focus, it's had great success, is building a comprehensive diagnostic program, diagnosis of peripheral vascular disease, pioneering new techniques, focusing on non-invasive imagery, as sees at least 5,000, his group, at least 5,000 outpatients per year and over 1,000 inpatient consultations and management. And main focus on renal artery disease, peripheral vascular disease, DVTs, and endovascular therapy to save ischemic limbs. So his research, he's a PI of many Mount Sinai sponsored studies and industry sponsored studies, again on peripheral vascular disease, also chemoembolization of unresectable tumors. And his clinical and research work is responsible for over 100 publications, including original articles and multi-specialty guideline documents. He plays a leadership role in analyzing healthcare delivery costs and looking at the data, and then can present that data to the health system in the context and the new milieu of changes in payment away from fee-for-service, now looking at bundle payment. He's recipient of many awards, including Outstanding Clinical Research Award from Journal of Vascular Interventional Radiology, and is a fellow of the Society of Vascular Medicine and Interventional Radiology, and is the Harold Mitty Distinguished Educator Award in Interventional Radiology twice, and was Teacher of the Year as a resident in radiology. So finally, before we hear the Grand Round presentation, he's Vice President of the National PE Response Team, the PRED Consortium, a national organization, and we are members here too with the main hospital. So PE Response Team, as many of you know, is a multidisciplinary team encompassing pulmonologists, interventional radiologists, cardiologists, cardiothoracic surgeons, cardiology, and more. And our responsibility is to respond rapidly in real time and discuss and activate management in patients at increased risk of death or mortality from an acute pulmonary embolism. And this is more important now than ever because, as you'll hear, there's increasing treatment options, but there's lack of consensus and evidence-based guidelines in guiding us as clinicians as what is the optimal therapy for these at-risk patients. I understand there are over 50 to 60 hospitals now and throughout the United States that are members of the PE Response Team Consortium, which is based in Massachusetts. And finally, I'd like to just thank Dr. Lookstein for being an ever-present member of our team. He is always contributing 24/7, 365 days a week, including yesterday evening, that continued into the early hours, for which we're very grateful for him providing support to our own interventional radiologists and the system support. Thank you.
Thank you, David, and thank you, Sam, for the invitation. I'm going to talk for the next 45 minutes or so about a topic that, as David expressed, is near and dear to my heart, which is something that, at least in my career, has been a very, very exciting clinical space to watch and observe. And there's going to be a lot of activity for the next several years, and it's specifically minimally invasive technologies and therapies to treat acute pulmonary embolism. These are my disclosures. I do consult for several companies that manufacture the devices I'm going to be discussing for the next hour or so. So just a little bit of background here. Obviously, pulmonary embolism and venous thromboembolism are unfortunately extremely common in the United States and in North America. Pulmonary embolism specifically is widely considered to be the most preventable cause of mortality amongst hospitalized patients. And there have been numerous sort of calls to action by the U.S. Surgeon General. This is clearly the time to sort of reinvest and refocus on this disease, which unfortunately I think previously has just not been given enough attention and enough resource allocation. So again, the incidence is extremely high in the U.S. We obviously know that the majority of symptomatic PEs originate from the lower extremity. And there's been a lot of research as to how that should be managed as well, but I'm not going to touch upon that. Unfortunately, the mortalities are extraordinarily high. It's estimated that deaths from acute pulmonary embolism outnumber car crashes, breast cancer, and HIV-related deaths combined. So it's not an insignificant risk to life. And again, respectfully, I would say that until somewhat recently, there just hasn't been enough attention to try and navigate this devastating disease and rescue these patients. I'm going to talk a little bit about some of the vernacular because it's important that we have a common vocabulary as we discuss different treatment options. So I think historically there have been conversations about, is this an extensive PE? Is it a, significant PE? And that's really not the way that people are referring to this anymore. And people, I think, now mobilize towards getting CAT scans, which I think has become the sort of gold standard for diagnosing pulmonary embolism. And they'll look at the CAT scan and say, my God, this is a significant, extensive, quote unquote, massive PE. They'll measure the level of obstruction to the pulmonary vasculature. And that's not really, unfortunately, relevant to how we on the front lines are trying to discuss this and manage it. It's really how clinically symptomatic the patient is. And so we're really, almost ignoring the imaging. The imaging is more binary. It's really, is there PE present or not? There's some subtleties, which I'll go into, but it's really what's happening to the patient. Are they able to oxygenate? Are they able to maintain their own blood pressure? Are they tachycardic, bradycardic? And probably most importantly, is the RV function compromised or not? And then beyond that, if the RV function is compromised, are they demonstrating evidence of myocardial ischemia with either a troponin leak or elevation of brain natriuretic peptides? Obviously, the EKG comes into favor as well. So here's a couple of cases. I think everybody in the room would say, yes, this is a saddle pulmonary embolism that's bridging the pulmonary bifurcation, extending it to both lobar arteries. Is this massive? Sorry. Here's another case, again, with a saddle pulmonary embolism, a different patient. And the question, again, is sort of, is this massive? How do we triage this? Should we treat this patient differently than the last patient, or are they all the same? And again, you need to take a broader look. You need to look at the patient's presentation. So the first patient I showed you is actually completely normotensive, has completely normal vital signs. The echocardiogram and the CT indirectly shows that the RV is not compromised. They have no troponin leak. They have no elevation of their BNP. And actually, even though it's a saddle PE, this is considered low risk. And this patient literally, I think by broad consensus, can be given a DOAC and sent home as an outpatient. Not everybody, but I think the majority of people in this day and age would say, give them Xarelto, give them Eliquis, send them home, and we'll see them in the office next week, et cetera. The second patient, unfortunately, is hypotensive. They're probably going to start vasopressor support soon. They're tachycardic, tachypneic, hypoxic, despite being on a non-rebreather mask. And again, this is a little subtle here, but you can see the RV is pretty blown out even on the CAT scan. This was confirmed by a transthoracic echocardiogram. And the actual diameter of the right ventricle is larger than the left ventricle. This patient is literally impending shock. And we would consider this certainly intermediate risk and possibly even a high risk pulmonary embolism. This patient would not go home. This patient would be admitted likely in a monitored unit and would be considered for rescue therapy or reperfusion therapy. And so again, just to summarize this, patients with normal RV function, with normal blood pressure, these patients are typically just managed medically and without any further need for admission or escalation. The high-risk patients, which I think we would all recognize, they're in cardiovascular collapse, they're in fulminant shock, they need to be rescued immediately, or else we're really concerned they're going to die during that initial presentation. This is a minority of cases. What we're really sort of struggling with as a collective, and I don't profess to have any brilliant answers here, but it's really where the entire clinical community is focusing on, is what to do with these patients here in the middle, the moderate risk or intermediate submassive PE patients. And these patients typically are able to maintain their blood pressure, but their RV has significant dysfunction when they're evaluated by TTE. And at least right now, there's consensus that these patients are at greater risk for adverse events. And again, you can dive into this even further. You can triage them based on how large the right ventricle is compared to the left ventricle, what the extent is of the elevation of the brain natriuretic peptide, what the EKG changes are they demonstrating myocardial ischemia, et cetera. But most of the focus is what to do with these patients right here in the middle. And again, just based on the epidemiology, they're not the majority of the patients. The majority of the patients, fortunately, are low risk, but they compromise about 40%. So it's not an insignificant number. And it really is, just by the sheer numbers, the majority of the patients that David and I are getting on, chats on it, 1 in the morning, 2 in the morning, is what to do with this population down here. Now, you might say, well, we all know that patients in shock, they're clearly at risk for having a significant mortality event or cardiovascular collapse. But what's not well understood is that these patients here that are at intermediate risk actually have a quantifiable risk of major adverse events or even mortality at 90-day follow-up. And I think that, again, that's why the clinical community is trying to mobilize for these patients and identify certain issues. So the greatest predictor is actually not the extent of the clot. It has very, very little to do with the CT findings at all. It has to do with how well the RV is functioning or not when the patient initially presents. And RV dysfunction, and specifically the severity of the RV dysfunctions, correlates very, very well to increased rates of mortality, adverse events, and actually VTE recurrence as well. One of the seminal articles in the space was published by Sam Goldhaber almost 20 years ago now. Sam Goldhaber is a vascular medicine physician who's been one of the national experts for the last generation on pulmonary embolism. He published the ICAPER registry in CIRC, again, just about 15 years ago now. This was a multi-center prospective registry looking at symptomatic PE across several dozen centers across the country, largely academic centers. And what he found, and this was again published in Circulation, was that patients with massive PE and fulminant shock had a 50% mortality risk at 3-month follow-up. And the mortality risk was almost immediate. And then it stabilized out moving forward. But the submassive or the intermediate risk PEs, they were not zero risk. And again, it was a slightly greater uptick in the curve, so that 1 in 6 patients approximately also had a mortality risk out to 90 days. And most of the work in the last 15 to 20 years has been trying to identify sort of who is at greatest risk here in this 15%, can we substratify them, and what's the ideal treatment strategy. Several other publications that have come out in the last 15 years, this was in chest, specifically looking at the size of the RV compared to the LV, looking at mortality rates. This is in-hospital mortality. So if the RV to LV ratio is normal, which means that the diameter of the right ventricle is 90% or less than the diameter of the left ventricle, the mortality rate in hospital is less than 2%. Whereas as long as you just tick it up greater than 90% of the diameter, it over triples. All right, so again, not an insignificant pattern here. Can you do this on CT? Yes. I would argue it's maybe not as sophisticated, not as well independently adjudicated, but more and more frequently the diagnostic radiology group is including these kind of metrics in their reports. And if you have any questions or concerns about this, you can call up radiology and just say, what do you think the RV to LV ratio is? And they should be able to create these very, very crude assessments to determine whether or not these ratios are elevated as well. What's the rate of adverse events out to 30 days? Here's a publication from Circulation. Again, this is not just mortality, it's all adverse events. So it's cardiovascular collapse, heart attack, stroke, etc. 50% if it's normal for patients who have acute PE. It goes up to 80% if the RV to LV ratio is elevated. And again, these are very, very sobering trends, obviously. This is another publication from the radiology literature solely looking at pulmonary angiography and CT scans. Again, looking at correlation of RV to LV ratio at mortality risk. So if the RV to LV ratio is less than 1, mortality at 3 months is 0 in this publication. As it starts to creep up between 1 and 1.5, it goes up to 8%, and it becomes greater than 1.5 at 17%. Again, very, very sobering findings. Close to lastly, RV hypokinesis associated with 40% increased mortality rates out to 3 months. And so if there's, again, no hypokinesis on transthoracic echocardiogram at 90 days, mortality is 15%. If there is hypokinesis, it goes up to 21%. Lastly, 4 times incidence of mortality if the patients are able to, unfortunately, not have their RV dysfunction resolved at discharge. And again, I think this is the pivot point here. So if somebody comes in and they have RV dysfunction and for whatever reason, their medical therapy, interventional therapy, surgical therapy doesn't resolve their RV dysfunction, the mortality rate at mean follow-up is 10%. However, if you are able to resolve it at discharge, it's as low as 2%. Again, suggesting that the RV is the entire key here is how do we rescue the RV? Here's just a follow-up study looking at CTEPH. For those of you who don't know what CTEPH is, it's chronic thromboembolic pulmonary hypertension, which is a really devastating chronic condition characterized by dyspnea, poor exercise tolerance, fatigue. There's almost no medical therapies for this. Surgical therapies are hard to find, hard to have access to, and it's associated, unfortunately, with very, very high levels of morbidity and even mortality. And so again, if you get discharged with RV dysfunction, by some estimates, a very, very high percentage will have CTEPH at follow-up. And the incidence goes up as you follow these patients out even farther from this article in New England Journal. So again, poor outcomes are associated with patients with RV dysfunctions who are treated, quote unquote, inadequately. And I'm not going to try and comment on what inadequate treatment is. But it really does beg the question, should we be more aggressive with this cohort to resolve the clot burden and reverse the RV dysfunction before the patients are discharged? And again, this is where most of the clinical focus has been, is who do we rescue and how do we rescue them? How do we identify this? Risk stratification is absolutely critical. You can't just look at the CAT scan. You need to really take a holistic view. The advanced therapeutic options up until recently have only included systemic fibrinolysis, basically intravenous TPA. I think we're all familiar with this. It's 100 milligrams over a few hours. But recently, surgical and catheter-based therapies have been given a sort of new look or a fresh glance. Catheter-directed thrombolysis, which is ultra-low dose thrombolysis given directly into the clot, has become very, very popular in the last 5 years or so. IV filter insertion, I think, is really dying down. It's been proven to really not be effective in treating anybody unless patients can't receive anticoagulation. And unfortunately, we don't have consensus right now on who should get any of these therapies. I'll try and discuss the guidelines in just a second, but we're really treating every single patient individually. And that really does beg the question of, how do we come up with individual criteria? It really is the focus of almost all of our late night conversations is, well, this patient's obese, this patient's elderly, this patient had a stroke 10 years ago, this patient doesn't want to get catheterization, this patient's going to be non-compliant with their medical therapy. And so it's unfortunately all individual right now, but it obviously creates tremendous opportunities for a lot of prospective research to identify specific patient cohorts. So what do the guidelines say? This is the most recent guideline document from the European Society of Cardiology. It was literally published online several weeks ago. And so now it's able to be downloaded and undergo review. Patients who are in hemodynamic collapse should receive rescue thrombolytic therapy, level 1 evidence, okay, grade 1 recommendation. Surgical embolectomy or catheter-directed treatment should be considered as alternatives to rescue thrombolytic therapy for patients who deteriorate hemodynamically. And again, that's patients where you consider them to be at ultra high risk for bleeding from fibrinolytic therapy or where it's not available. Other recommendations for percutaneous therapy, patients who are at high risk for bleeding for thrombolysis or where thrombolysis has failed, unfortunately a 2AC recommendation. Reperfusion therapy, again, patients who with hemodynamic deterioration and anticoagulation, a 1B recommendation. Percutaneous rescue or surgical rescue should be considered for patients with hemodynamic deterioration on anticoagulation therapy. And then routine systemic fibrinolysis is not recommended for patients with submassive or low risk PE. Lastly, this is brand new, hot off the presses. A team-based approach should be considered if you have the local resources or expertise. And again, as David alluded to, we've been very, very proud that we have a very, very humble and respectful team-based approach to dealing with PE across the entire system. So what do you do with submassive PE? I'm going to try and talk about the evidence base and give you the prelude of how we went into endovascular therapy. This was a seminal randomized article, again, over 20 years ago, with 250 patients with submassive PE. This is not patients in shock that, it was very, very clear they need to be rescued. This is patients with solely RV dysfunction. Were randomized to heparin versus heparin and TPA, standard 100 milligram infusion. The outcomes were in-hospital death, need for escalation, meaning that they deteriorated even further, or recurrent PE, major bleeding, or stroke. This is the publication, was published in the New England Journal. Again, 256 patients randomized. The primary endpoint was significantly reduced for the patients that got alteplase, again, full dose TPA. And it really did sort of beg the question of, wow, this is really interesting. Maybe this should be offered in a much broader sense. Escalation therapy was reduced as well. Need for secondary thrombolysis, again, a secondary indicator that the patients are deteriorating further, again, reduced significantly. The PYTHO trial was a follow-up study. It didn't use alteplase, it used tenecteplase, which is, just as an aside, not a formulary in this system. But it was felt at the time when this trial was initiated about 15 years ago to be a more effective, safer agent. And this unfortunately hasn't really held up, and it's unfortunately much more expensive than alteplase, which is one of the reasons we don't stock it here. But this was essentially a larger multi-center international trial of the same concept I just showed you. So it's submassive pulmonary embolism heparin versus heparin plus full dose fibrinolytic agents. And again, the primary endpoint of major adverse events, mortality, was significantly reduced in the group that got a fibrinolytic agent. Unfortunately, major extracranial bleeding was significantly elevated, a 6-fold increase, or a 5.5 odds ratio of having a major extracranial bleeding event. Stroke was elevated as well. And this largely dampened any enthusiasm for the liberal use of fibrinolytic therapy for patients with submassive PE. In addition to that, when you looked at patients with who were older than 75 years old, these patients had less clinical benefit, meaning that the signal towards freedom from the primary outcome was reduced, and unfortunately, the bleeding rate was actually higher in that cohort. Here's another variation on this theme. This is, intermediate dose TPA. So, well, if we're trying to avoid the bleeding risk, what if we just cut the dose in half? And again, this was a relatively small series, more of a feasibility study. This is going to be replicated in a much, much larger cohort, probably in the next 3 to 5 years if they can get funding. But again, it's anticoagulation versus 50 milligrams of TPA instead of 100 milligrams of TPA versus anticoagulation alone. And their primary endpoint was the incidence of pulmonary hypertension and freedom from recurrent pulmonary embolism. And again, you can see a statistical benefit favoring the patients that received sort of intermediate dose fibrinolytic therapy here. Again, reduction in recurrent pulmonary embolism as well. No bleeding complications between either of the two cohorts, and then reduction length of stay, which is obviously a very hot topic now. I think we're all dealing with issues of how to get people out of the building faster. So a seminal meta-analysis was published in JAMA just 5-6 years ago. And this included many of the studies that I've mentioned already this morning. And you can see there's a trend favoring the use of thrombolytics for patients with submassive pulmonary embolism. This was published again in JAMA, and this is straight from the publication here. The mortality rate was reduced, again favoring fibrinolytic therapy, but unfortunately the major bleeding rate almost tripled. And so the number needed to treat to save one life, estimated from this meta-analysis, was 65, but the number needed to harm to have a major bleeding complication was only 18. And so again, this really further reinforced the idea that liberal use of full dose or even half dose fibrinolytic therapy was perhaps not ideal because of the significant risk of major bleeding complications. So welcome to the modern era. And what are the current dilemmas? What are the issues that we deal with on a regular basis almost every single night? We sort of struggle with this idea that maybe submassive is not a homogeneous cohort, and can we identify a quote unquote high intermediate risk PE? Maybe it's patients that are leaking troponin. Maybe it's patients with very significant EKG findings. Maybe it's patients with completely hypokinetic right ventricles. We don't know right now, and there's not broad consensus, but this is the majority of the focus of the conversations that we have late at night about what to do with these patients. Should all of these patients, whoever these patients are, get some kind of intervention that's not fibrinolysis? Should they get surgery? Should they get catheter-based therapy? Something that's become popularized is ultrasound-based catheter-directed thrombolysis. I'll discuss that in just a moment. And is that really necessary? What is the role of thromboaspiration, which is placing a catheter into the pulmonary artery and literally aspirating out or sucking out the clot? How do you manage clot in transit? That's a clot that's in the right atrium that's sort of bouncing around the tricuspid valve, and where you're concerned if it were to project through the right ventricular outflow tract, the patient would go into shock. What do you do with those people? Does anybody need a filter? And I would argue probably not. Most of these patients don't need filters. And what are the performance goals for surgery? Meaning that, just as a broad example, I don't think any of the surgeons in the room, and most of them are my friends, but are they keeping track of their outcomes? Do we really know what our mortality rate is for acute PE? Do we know what our morbidity rate is? And is that widely disseminated to the medical group that's triaging these patients at the front line? So we struggle with systemic thrombolysis for an intermediate risk cohort, even a relatively high risk intermediate risk cohort. And we're trying to balance the bleeding risks with open surgery, because there's a lot of literature for open surgery. And if you ask most of the surgeons, they say my outcomes are absolutely great. And again, with all due respect to our surgical group, and I think they are wonderful, the last time I actually asked one of our surgical colleagues, that David might even been in the room, and this was probably the most experienced surgeon we had in the entire system, he said my major morbidity rate was 25%, including an 18% incidence of tracheostomy and chronic respiratory failure. All right, I didn't know that. And I was sort of like, wow, when we're getting consent for this kind of stuff and we're sort of weighing the different options, if we were to actually share that with the patient, I'm not sure that they would sort of volunteer to have that. Okay. Now, again, the mortality rates are very, very low, in low single digits, but it's not free of morbidity. And the question is there an opportunity here for something that sort of balances the two? Can you minimize the bleeding risk? Can you minimize the morbidity? And is that endovascular therapy? I'm not saying that it is. I'm just going to try and sort of get you attuned to what we're talking about right now. The idea is not to remove the entire clot. The idea is to either break it up or break it down so that you don't have as much pulmonary vascular resistance, take the strain off the right ventricle, again, eliminate or reduce the RV dysfunction before the patient goes home, with the idea that that will change the natural history of this disease process in this at-risk cohort. This is what's referred to as ECOS catheters. This is ultrasound accelerated thrombolysis. And these are typically threaded in through the femoral veins. And you can see one catheter is going into the left pulmonary artery, one catheter is going into the right pulmonary artery. And this was the sort of catalyst that really brought to the forefront this endovascular revolution. There have been several publications in pretty high impact journals, including European Heart Journal, Circulation, JACC, describing benefits of this technology. The idea on the bench is that the ultrasound, the dark red here is where the TPA is going. The ultrasound facilitates dispersion of the lytic into the clot. So if you stick the ultrasound into the clot, the TPA is going to be more readily absorbed by the clot, facilitating fibrin breakdown and facilitating more faster lysis. That's the concept. And again, decrease pulmonary vascular resistance, reduce PA pressure, take the strain off the RV, use low-dose TPA to reduce the bleeding risk, improve systemic arterial pressure, and recover the right ventricular function. So these are the trials. I'm going to go through these very, very quickly. The first trial was a randomized trial out of Europe, which again looked at the ability to rescue the right ventricle with the introductions of these ECOS catheters into the pulmonary circulation as compared to patients just receiving heparin alone. A very, very small feasibility study. It was about 60 patients randomized. And again, the efficacy was solely, can you take the strain off the RV at 24 hours and 90-day follow-up? And then what does the RV function look like afterwards? And this was the safety profile, which I think we would all want to see: bleeding avoidance, VTE, and death. Essentially, submassive PEs were included. Anybody with a history of stroke or active bleeding was excluded. These are all intuitive for a fibrinolysis trial. And again, this was the randomization scheme. It was about 60 patients randomized to heparin versus heparin plus these ECOS catheters. The demographics were similar between the two groups. This was not a relatively healthy cohort, so that there was a troponin leak in 3/4 of the cases. And so I think this was patients that we would all agree should probably have some consideration to have something done. The endpoint was determined by transthoracic echocardiography. And again, I alluded to this, is what's the size of the RV compared to the LV. So here's the primary endpoint. If you look at the RV to LV ratio for heparin, there was no significant change whatsoever at a 24-hour follow-up. However, when the patients received this ultrasound accelerated thrombolysis, and the typical dose of the TPA was quarter dose, 20 to 25 milligrams of TPA over 12 hours or so through these catheters, there was a statistically significant reduction in the RV to LV ratio, suggesting that perhaps this could take the strain off the RV and maybe rescue these patients here. What happens out to 90 days? Again, it appears at 90 days that the patients treated with heparin, there is some improvement here in the RV to LV ratio. It did not reach statistical significance by this analysis. However, the improvements seen at 24 hours continued to be seen out to 90 days. Again, suggesting in a very, very small randomized trial that this might be ideally suited for a submassive population. And then if you look at the sole endpoint of how good does the RV work, at follow-up at 24 hours and 90 days, there are significantly more patients with normal RV function 90 days as compared to the group treated with heparin. Again, suggesting that perhaps this might be potentially beneficial. Adverse event rates were very, very, very low between both groups, and there was no statistical difference whatsoever. So the conclusions: it does improve the RV to LV ratio, and it improves the systolic RV function. Follow-up study was a non-randomized study. This was a multi-centered U.S. study. Over 100 patients were included for this, included massive and submassive PE. The almost exact same endpoints here. Instead of now being at 24 hours, it's 48-hour follow-up. Same protocol: ECOS and heparin versus heparin alone. Again, very similar demographics here, no significant difference. And again, ultra low dose TPA, about 25 milligrams as well. And almost the exact same findings were seen. So you see a statistically significant reduction from 1.55 in the RV to LV ratio down to 1.13. The Miller index was reduced in a statistical way as well, so that the findings on CAT scan and follow-up demonstrating how much of the pulmonary circulation is obstructed was reduced. That was significant. The pulmonary artery pressures were reduced from a systolic blood pressure of 50 down to a systolic blood pressure in the high 30s, and that continued out to 48 hours. This cohort did have some bleeding risk. A couple of patients unfortunately expired. This again included massive PE, so it's not that surprising to see adverse events associated with a much sicker cohort here. Mean length of stay 9 days, which I think we would all agree is probably a little bit long But again, this was the outcomes for this. And again, recognition that perhaps this technology is able to improve RV to LV function and rescue the patient here. The last study that I'm going to mention on this technology looked at different dosing schemes, different duration of therapy. From the first two studies, it was put in these catheters, turn them on for 12 hours, give the patient 25 milligrams of TPA. And then everybody said, well, what if we went ultra fast? What if we put in the catheters for 2 hours, 4 hours, 6 hours? What if we only give the patient 4 milligrams of TPA, 8 milligrams of TPA, 12 milligrams of TPA? Is that enough? And so this was a prospective randomized 4-arm dose escalation study using these ECOS catheters with different groups. So everybody got some kind of invasive therapy just for different doses and different durations. Again, same outcomes, RV to LV ratio at 48 hours, same bleeding risks out to 72 hours here. And again, quality of life scores and 6-minute walking tests were measured as well to try and give a more patient-centric assessment. Again, submassive PEs were included, bleeding risks were excluded here. This was the dosing escalation theme. 8 milligrams total, 12 milligrams total, 24 milligrams total, and then the times are obviously listed here. Demographics were identical between the entire group, again, with a prospective randomized study. And interestingly enough, the efficacy was almost identical across all 4 doses. And I struggle to how to interpret this data myself, honestly, but you saw, again, a significant reduction in the RV to LV ratio from before the procedure to after the procedure, regardless of the dose and the duration that the patient received. This persisted out to 1 year without any significant benefit for any of the dosing schemes whatsoever. A dramatic reduction at 48 hours, but again, it continued out to 1 year. Again, the PA obstruction score, the Miller score, again, significant reduction across the entire group. A little bit of a trend towards improvement with a higher dose and a longer dosing scheme there. 6-minute walk test improves across the board. Interestingly enough, the greatest benefit seen in the 6-hour group instead of the 8-hour group. Again, I struggle to interpret this on my own. Quality of life dramatically improved, but again, no difference between the quality of life improvements between the different cohorts. And again, significant reduction in their subjective complaint scores across the cohorts as well. Bleeding risks, again, bleeds were seen in this, relatively low, but again, no difference between the 2 groups as well. And again, people struggle with this. I struggle with this. David and I talk about this, but at the end of the day, I think we're not using this to move the dial necessarily. It's just another contribution to the evidence base here. What do these patients look like after they've undergone this kind of catheter-based therapy? Here on this pulmonary angiogram, you see a major clot here in the left lower lobe, obstruction of the lingula, poor perfusion to the left upper lobe. And then after this thrombolytic course with 18, 20 milligrams TPA, you just see improved perfusion. The clot is still there, but it's reduced in size. And so you're not taking out the entire clot, you're really just reducing it by 40, 50, 60% and improving the perfusion to the organ. That's really what the goal is here. We looked at our first 20, 30, 40 cases here. We saw significant reductions in the PA systolic pressures. We had no significant bleeding rates. We had 2 minor bleeds. This is not completely up to date here, but our protocol was 25 milligrams of TPA as per the initial feasibility studies. All the patients had reductions in the PA pressure. And so again, we were in line with the published literature. There have been several other single center series published that again demonstrate that this technology can reduce the PA pressure, not only systolic, but mean PA pressure as well in a variety of different peer-reviewed formats. So we treat submassive PE with this catheter-directed therapy because we think we can prevent short-term adverse events and do it without the bleeding complications associated with systemic high-dose therapy. Now I'm going to talk about what we've been dealing with for the last 3 to 4 years, which is that is there something else for patients that can't get thrombolysis? And that's this aspiration technology. The rationale is what if you didn't have to put in catheters and watch somebody for 4 to 6 hours? What if you could just put in a catheter and quote unquote suck out all the clot, all right, in single session? Would that be interesting? Now, I'm an endovascular practitioner, and so this interests me tremendously. But the idea is that you could avoid a high-dose lytic infusion, avoid lysing the patient overnight, which we frequently do in the current state. On the table, lower the PA pressure. On the table, improve the RV function. Rapidly remove clot. And what if it was safe? We're not there yet, okay? But wouldn't it be great if we could get there? And I would respectfully argue, yes. Would that change practice? I think it would, because I think there's an unmet need here. The reason I think there's an unmet need is because this concept has been completely realized for STEMI. You know, you sort of, patient shows up in the ER, they go to the cath lab, they get a stent, done. Sometimes a little bit more complicated than that. Same thing now for stroke. I think we're all aware of this. Patient shows up in the emergency room with a stroke. They go to the IR lab and they suck out the clot, and it's patient's rescued immediately. The results are very, very dramatic. We're doing it for DVT, for patients who have very, very symptomatic lower extremity DVT. We have single session therapy. The patients get off the table, they're given Lovenox, and they can go home. It's ambulatory therapy now for symptomatic acute DVT. So why not PE? There's been a number of different technologies, a number of different widgets or tools, toys, whatever term you want to use. There's not any clear consensus on which one's ideally suited for any specific patient population. The problem that we deal with, which is why there's such a litany of different technologies, is that the clot that's extracted through an open surgical embolectomy is massive. Here's what you take out from a STEMI, here's what you take out for a stroke, and then look what my friend Brent Keeling down in Emory sent me of what they take out of the pulmonary artery during an open embolectomy. Can you imagine a catheter taking this out? So again, very, very, very sobering. But everybody's mobilizing to try and fix this, all right? And again, this is one of our surgical specimens from the east side. Again, it's just humbling to think how a catheter is going to get this out, but everyone's working on it. So could you debulk it? Could you eliminate the need for overnight lysis? Could you actually replace surgical embolectomy if it wasn't immediately available for high-risk patients? Could you identify a cohort where you could reduce the morbidity of open surgery? And then could you expand the treatment profile to a broader population that would perhaps be considered high risk for open surgery, maybe patients with advanced COPD, just as one example. So here's the first technology. This is called AngioVac. This was developed by one of our own surgeons who's since gone on to become an entrepreneur. But it was one of our cardiac surgeons developed this technology originally as an open surgical technology. It's now percutaneous. This is a 22 French cannula that's thread percutaneously into the pulmonary artery. This is just a cartoon demonstrating it. You put the patient on a perfusion pump and you essentially exsanguinate them. The clot is trapped in a filter that's outside the patient. This cartoon represents that here. The pump transfuses the blood back into the patient through a separate cannula in the other site. And again, this avoids an open sternotomy, an open thoracotomy. You know, it's very, minimally invasive, even though it's a 22 French cannula. Very, very little in the published literature about this technology for pulmonary embolism. This technology is now almost 8 or 9 years old. This is from my friend John Moriarty, who works at UCLA. And he did 5 cases, ruptured the right ventricle in one of the cases, trying to get it through the pulmonic valve, and basically said, we have limited success. We need to have further study and very, very careful patient selection. The company took this very seriously, and now they're developing a much more flexible, deliverable platform that should be safer. But again, this is sort of where we started, a giant cannula that could either avulse the tricuspid valve or rupture the right ventricle. There's an ongoing prospective registry, which we participate in interventional radiology to try and look at safety outcomes related to this. Here's just a fluoroscopic image of this giant cannula being delivered into the pulmonary artery. This is over an incredibly stiff wire, which has the ability to really hurt the patient. And so we use this very, very, very sparingly in our current practice. One thing that we've adopted this for those of you who do echocardiography or interpret echocardiography, you'll notice this sort of mobilized clot in transit here. abutting the tricuspid valve. And this is what I was alluding to before. This technology is actually extremely good at dealing with clot in transit. And I think many of us have mobilized towards being comfortable of using this because you don't have to get it through the tricuspid valve to deliver it. And this was a case at St. Luke's a couple of years ago that Gabe DiLuoso and I did, where we got this very large clot in transit out percutaneously. And the patient was able to go home just a few days later. So just one application for that technology that we think resonates well. Second entrance into the field is a non-perfusion based system, but again, a 20 French catheter that's introduced into the pulmonary circulation. This is actually now FDA approved for clot removal in the pulmonary circulation. This mesh-like network net is sort of used to yank the clot out of the pulmonary circulation. They had a prospective multi-center feasibility study that was endorsed by the FDA, which completed enrollment, was published in JACC, where again, they saw a reduction in the RV to LV ratio at a 48-hour follow-up, which again demonstrated efficacy. Interestingly enough, the greatest benefit was seen in patients with elevated PA pressures when they catheterized the patient. Patients with normal PA pressure demonstrated no benefit whatsoever. Interpret that how you will. Another follow-up study in Journal of Vascular Interventional Radiology where they looked at 40 patients here. And again, very, very impressive results using this technology to aspirate clot out of patients with typically submassive pulmonary embolism. This is one case we did recently. On the east side, you can see again how big this catheter is. It's a little bit of a learning curve to navigate this through the tricuspid valve and the right ventricular outflow tract, and this is the clot that we were able to aspirate in this patient. This patient was actually deteriorating and was felt to be at high risk for bleeding from TPA, and so this is why we use this technology. This is associated with aspirating blood as well as the clot out, and so you can see significant anemia on the table. And again, major complications are not insignificant, largely related to delivering this very, very large bore device. So maybe not ready for prime time, but certainly intriguing. The last technology is an 8 French catheter. This just got FDA approval in the last month. And for those of you who know how the stroke team works, this is the exact same system that's used by stroke, but it's bigger to be able to be delivered to the pulmonary circulation. This is only 8 French. It's ultra low crossing profile here. A number of peer-reviewed publications demonstrating safety and feasibility. And this was the multi-center prospective study. Jim Horowitz and Aki Sista down at NYU sort of spearheaded this study. And just to go to the safety endpoints here, they screened 500 patients to enroll 110. And again, the reduction in the PA pressure was met, demonstrating efficacy. Again, solely aspirating clot here without receiving TPA. RV to LV ratio was significantly reduced, again, demonstrating efficacy for a small bore catheter. Adverse events were low. 2 patients died acutely, basically, due to injury. So again, this is not completely 100% safe, but it could be an alternative for patients who have a contraindication to fibrinolytic therapy. And again, this is the adverse event profile here. Essentially, 2 patients died almost immediately from being catheterized, essentially. If you look at all these different technologies across the board, the efficacy seems to be reproducible regardless of whether you use catheter-directed lysis or if you're not using TPA, if you're using large bore aspiration or a small bore aspiration. The bleeding profile is obviously reduced if you're not using fibrinolytic therapy, and the mortality rate appears to be identical. One thing I appreciate is the low procedure time in the small bore system, which doubles as you go to the large bore systems and increases exponentially as you go to catheter-directed thrombolysis. And this is important to consider whether or not a patient can tolerate a prolonged procedure. This is just a case with a small bore procedure. This is a pulmonary angiogram on the right side where there's no perfusion to the right middle lobe and right lower lobe. This is the 8 French catheter. This sort of spinning wheel here is pulling the catheter off the wall. And then the follow-up here, you see return of perfusion to the right middle and the lower lobes. And again, this patient on the table had a reduction in their PA pressure and actually did very well and was discharged 2 days afterwards. Nationwide use of catheter-directed thrombolysis, this is the blue curve here, is going up at an almost exponential rate. I would respectfully argue there's not clear consensus on who to use it on. But again, it just sort of begs the question of this clear opportunities here to generate prospective research and try and identify which patients are ideally suited. Two technologies that are probably going to come up for research in the very, very near future. This is what's called the Bashir Calf. This was developed by Riaz Bashir, as a cardiologist at Jefferson outside of Philadelphia. The catheter is like a 4 to 5 French catheter introduced down here. You literally press a button and this basket opens up. Every single time on the basket infuses TPA, which might get better penetration of the fibrinolytic agent than just the single, tube catheters that I showed you before. Again, the idea is to increase the efficacy of exposure of the clot to the fibrinolytic agent. This is just one case that Riaz shared with me with extensive clot in the pulmonary circulation here. The cardiac index and cardiac output were compromised. This is how the catheter looks on fluoroscopy. This was part of a first-in-man study. A pivotal study is coming up probably later this year. And you can see improvements in cardiac output, cardiac index at follow-up, as well as reductions in PA pressure and right ventricular function. Here's the follow-up angiogram, demonstrating, as bad as the CAT scan looked, there's massive lysis of the clot with almost normal perfusion to both sides of the pulmonary circulation. Patient saturating very, very well. The RV to LV ratio is back to normal after that course of therapy, and you can see very, very dramatic lysis of the clot. So again, the FDA has approved a pivotal trial, which will be a multi-center prospective study looking at this technology, and again, we're going to look forward to studying that prospectively. Perfusion scan to follow up, again, basically normal perfusion scan. And then lastly is a different variation on an aspiration catheter where saline is injected to prevent the catheter from clogging up. This is about to start first-in-man trials and maybe just a different concept to improve the outcomes already seen. We have, again, aspiration with an 8 French catheter, which is small bore. We have these large discs and the vein-vein bypass, which is large bore. I personally think there's an opportunity somewhere in the middle here, and a number of the technologies are trying to increase the deliverability of an aspiration system and decrease the morbidity associated with a large bore system, but we're not there yet. So numerous devices currently exist to aspirate PE. They've all been used clinically, and they demonstrate feasibility to be able to be delivered to the pulmonary circulation and aspirate clot. At present, unfortunately, there's no consensus regarding appropriate use and which device is most appropriate for which clinical presentation. The prospective research studies are desperately needed. We're participating in several of them, but there's been opportunities to participate even more as we move forward. Again, my bias is I really believe there is an opportunity for a single session therapy, but there is a lot of work yet that needs to be done. Just to give you a very, very brief glimpse into the future, these are likely funded research studies that are going to happen in the next 12 to 24 months. There's a submission from my colleague Aki Sista at NYU to NHLBI for a prospective randomized study looking at catheter-directed thrombolysis versus heparin for a very, very large national cohort. The inclusion criteria is anybody with RV dysfunction. So you can be completely hemodynamically stable, or you can be leaking troponin and tachycardic and very, very symptomatic. They're looking at quality of life outcomes out to 1 year. We've already been asked to possibly participate in this study, assuming it gets a good score and full funding. There's another industry-sponsored study which is trying to identify a higher risk cohort, so only including patients that are leaking troponin, that have elevated BNP, that have abnormal vital signs, really looking at the sickest of the sick without having hemodynamic collapse, and randomizing 500 patients across the world. And there have been tremendous interest across Europe already to participate in this. And this would be ECOS versus medical therapy, solely looking at adverse events out to 90 days. And this is likely going to get funded later this year. And we will likely ask, the Mount Sinai Health System will likely be asked to participate in that as well. And then the 2 devices I just shared with you, those will likely be feasibility studies leading to potentially FDA approval for that sort of novel catheter-directed thrombolysis catheter and the thromboaspiration system. And on that note, I'm going to close. Thank you for all your attention this morning. questions, criticisms?
Hi, Dr.
Critiques? Yes.
Which site?
We'll do West, Norma.
Thank you for a really high-speed train ride through the very complicated topic. I have a comment and a couple of questions. One is that a long time ago, I think it was in the mid-70s, which I guess dark ages, there was a radiologist who did a study in dogs. Now, the dogs were all healthy, which of course is not our patient population. Nevertheless, he took dog blood, let it clot, and he put it with tantalum, and then he injected it in the dogs. And he could now track the progression of pulmonary embolus in the dog radiographically. And what was remarkable in that experiment, and having seen some of the videos of that, was that a large clot, massive, submassive level, including both pulmonary arteries and the main pulmonary artery, the right ventricle dilated immediately because of such a complete occlusion. But the right ventricle initially had very poor contractile function due to acute dilatation. And then within about 30 seconds or 45 seconds, less than a minute, suddenly the right ventricle kind of picked up, whether it's a Starling curve issue or not, I don't know, but it suddenly then burst the clot, and the clot was distributed to the blood flow, which now could be tracked with tantalum. So I found that a very intriguing experiment to show that there is a elasticity to the system that can compensate. That's what leads me to my question, and that is the tremendous differences in responses regardless of what system you use. Is any of that predicated on underlying previous comorbidities, especially things like chronic obstructive lung disease, interstitial lung disease, in which those patients may already have increased right-sided pressures from the underlying lung disease or from hypoxemia? So would that contribute to some of the diverse and different responses? Because no matter what we do, there's no perfect system. The other is obesity, because sedentary dogs are hard to get away from sedentary, especially if they're normal. But humans, the bigger they are, the more sedentary they are, and therefore does that increase the risk of not only VTE, but also embolism and its recurrence. Then lastly, were these patients controlled for underlying coagulopathies before you start any procedure?
I'll go in reverse. So typically we don't test for coagulopathy before we initiate any of these escalation therapies that I just described to you. That's typically managed as an outpatient once the patient's discharged. We usually navigate it in the acute phase by just making sure that their coagulation profile is demonstrating therapeutic efficacy of the anticoagulation regimen, and we don't dive into genetic analysis. The second question was obesity. Yes. I think David would echo this, that a very, very, very high proportion of our patients that we're seeing with symptomatic PE are obese. I think this is a nationwide global epidemic, and until we sort of get that message out there that obesity is an independent risk factor for a symptomatic life-threatening PE, I don't think we're really serving our patient population. So I couldn't echo that sentiment more. And then lastly, to paraphrase your question, if I understood it correctly, is how do you distinguish between an acute presentation and an acute deterioration of RV function versus a more chronic indolent presentation? And we'll be very candid, we struggle with this on a daily basis. And just the case last night that we were talking about was really somebody who came in with RV failure, about whether or not this was a chronic presentation or an acute presentation. And we try and use biomarkers, and we try and use a patient's subjective history to try and help us, but we still struggle with this. There's no radiographic criteria that we can use to look at a clot on a CAT scan, determine whether it's acute or chronic. And so we really are looking at all the patient variables to try and make a determination. I personally think that intervening on a chronic patient is not beneficial and is only associated with morbidity. And so this is a lot of the granular points of the conversations that we have on the PERT teams every single day and every single night about who's more of a chronic presentation, who's more of an acute presentation. I think we all feel comfortable mobilizing escalation therapy for an acute presentation, but we clearly struggle with it. I hope those answers were okay.
Oh, thanks.
Sure.
So I was just wondering, in terms of the RV dysfunction, is there a premise that you have in terms of why, when you're looking at the RV dysfunction, and the idea is that RV dysfunction correlates with mortality, and that's why it's significant, why there isn't a mortality difference if there's an RV dysfunction difference, like in the Ultima trial?
I'm not sure I understand what you're asking me. I'm
I
sorry.
thought you did a really nice job showing us like why RV dysfunction is important.
Right.
That study from.
So, okay, now I think I understand your question. The question is, why wasn't there a mortality difference in Ultima?
Yeah.
Okay, so Ultima really only had short-term outcomes, all right? And it was really trying to demonstrate at 24 to 48 hours whether the RV to LV ratio could change. That was the primary endpoint. It was not a mortality study. And so right now, that was the last trial that I was alluding to, which is probably going to get funded later this year, is going to be a prospective randomized trial of probably 500 patients, 250 patients getting catheter-directed thrombolysis with ECOS versus just heparin alone, looking at all adverse event rates out to 90 days. The belief is that that will be able to demonstrate a MACE difference, whereas the previous one was really only looking at very, very early outcomes, was not able to detect it. It also wasn't the primary endpoint.
We're still doing this here right now.
Yes,
right?
we are.
So I don't understand how you tell a lady, like, your RV might improve, but you might have major bleeding.
So from
I don't understand how you consent patients for this right now.
No, I totally understand the question. So all of us struggle with this. Okay, now I'm not saying that there's broad consensus about this, and many of the conversations we have on the PERT team are pretty contested conversations. Yeah. Okay, so I think that when the patient presents and you look at them and they appear to be in distress. And in the back of your mind, you're like, oh my God, if this patient goes into shock, we're not going to be able to save them. What can we do to try and prevent them from going into shock? It is much more of a gut reaction based on the patient's clinical presentation, based on what the family's saying, on how comfortable the patient was doing an hour or two ago, based on what the patient says, I'm a high performance athlete and I literally can't walk down the hall to go to the bathroom, okay? And those are the kinds of issues that we struggle with, was should we offer this patient something? In those settings, and they're really patients that are in distress typically, is we really say, we could give you 100 milligrams of TPA. We're concerned that that could cause a very significant bleeding complication, and we're not sure we should be offering that to you. You could have surgery, but it's open surgery on cardiopulmonary bypass, and that might sound a little bit scary, but there's something in the middle that we'd like to offer you, all right? And the theory is that if we give you a very, very low dose of the lytic agent directly into the clot, that we think we're gonna make you feel better, we think we're gonna reduce the risk of you having a complication here in the building, and we think, we don't know, that it's going to hopefully improve your quality of life and reduce adverse events at 30 days, 60 days, 180 days, et cetera. No, there is none, okay? And I'm beyond transparent when I consent patients about this.
This is not standard treatment. This has no evidence that it's going to improve your lifestyle, but it is an option as opposed to just sitting there and waiting. Because that seems like what the conversation should be.
Again, the exact tone of the conversation varies on the patient, obviously. But there appears to be, more and more every year, independently adjudicated with, data safety monitoring boards and clinical event committees, data that suggests that the concept that it's taking the strain off the right ventricle acutely does work, okay? What that translates to in a prospective manner at 180 days and 365 days, we don't have that data, which is why these two other large multi-center trials are going to get funded, because there's consensus that we need to generate that data to prove that the standard of care should be perhaps, okay, humbly, perhaps something more than just heparin, okay? But we're all speculating based on these small, feasibility studies, and we're extrapolating that to a larger cohort. I'm being fully clear. There's not level 1 evidence, which is why in the AHA guidelines and the ESC guidelines, there's not a level 1 recommendation to do this on every intermediate risk patient. We are literally treating patients individually based on what we perceive. And so an 85-year-old woman who never gets out of bed, who's just a little tachycardic, we're probably not going to rush in to do escalation therapy. But if, God forbid, somebody in this room all of a sudden couldn't breathe, was tachycardic, and their RV was completely blown out, we would all be like, my God, this is one of our cohorts. This is one of our friends, one of our colleagues. Maybe we should think about offering them something.
Okay, and then I just have one other question, and I think that this is relevant to, you presented a lot of studies that seem to be funded by pharmaceutical companies. And so when you look at your Sunshine Payments report on open payments, you received $47,000 from different pharmaceutical companies in 2018. Like,
there weren't pharmaceutical companies, they're medical device companies, just to be very specific.
Would you just explain what that means for someone interpreting this?
Yeah, sure.
It needs to be interpreted.
Yeah, absolutely. So without going into each of the specific companies, most of those funding sources are for travel. And I serve on multiple medical advisory boards for numerous companies. And so it ends up being hotel, airfare, payment for time, and payment for essentially intellectual content regarding the design of these trials. It's not all of it, but it's probably 80 to 90% of it. And I think when I showed my disclosures, I do sit on the medical advisory boards for multiple companies. In addition to that, the research programs that we participate in, and one example was the Penumbra Cat8 system. We enrolled 2 patients into that trial. The manufacturer and sponsor of that study paid the Icahn School of Medicine over $10,000 last year for us to enroll those 2 patients. My name is on that check. And so Open Payments put that $10,000 from Penumbra on that check for me, even though it's going to the medical school to fund my research associate and my research coordinator and my IRB fees, et cetera, et cetera, et cetera. So to say that it's going into my own personal pocket so I can go, do something personal, I don't think that's necessarily accurate. Okay.
Thank you for
But thank you for the question.
One of my favorite topics.
Sure.
And certainly these late night pages and text messaging is certainly without some sort of difference in opinions, and it's not fun to go up against cardiac surgeons and others.
I think we're all in the same boat. We're just trying to save people's lives. That's it.
The collaboration has been really nice, just in terms of putting all our heads together and doing the best thing for the patient. My question to you is, a quarter of the population has PFOs and other right to left shunts, which open up during these acute events. How do you, because a lot of the work that you've shown or the work that you do works within the right-sided vascular tree. So how do you prevent stroke in these sort of patients? As procedures, you worry about all these things.
I couldn't agree more. My gut is, and I wish I could prove this, but I can't. I can just prove it anecdotally. I would be hard-pressed to remember a case of a PE that we've all participated in where somebody had a stroke during the acute presentation. And so it's hard for me to explain why this is the case, but I think it's a little bit more of a theoretical risk than a pragmatic risk. If it was alternatively 1 in 4 patients we were seeing were having an embolic stroke during these acute presentations, I would be a little bit more, motivated about it. The pragmatic response to your question would be that, well, if you're going to go in, close the PFO at the time. I mean, it's all same catheter-based therapy, and actually these 20 French catheters, those PFO occlusion systems and the ASD occlusion system, they go through those systems anyway, so you could do it. But I struggle to remember one patient where they had a stroke during the acute presentation. Why that is, I can't really explain. But I think it's something we all sort of think about, and we obviously value the contribution of the transthoracic echo, but it just has not been a pragmatic day-to-day concern that I think it would change practice from a technical point of view.
And just left. We've obviously been tracking our own safety data, and it's been extremely good. And even those of us, myself included, who were maybe non-believers in the beginning, has really brought on. I think that's what the national data shows us as well from all the large number of files. So thank you for your.
I think that goes to a very, very conservative approach and not liberal adoption of all these, more invasive strategies.
So, thank you for the talk.
Sure.
Just one question is that it seems to me that, of course, there's a lot of controversies in the right treatment for these patients, but I think one of the key part here is to be able to identify the patients that will benefit from this sort of escalation therapy. So I think, and of course, it's just based on a very limited anecdotal experience of the last 3 years as a president, but I think the current classifications of PE that we have really don't do a good job at identifying the patients that are going to crash, particularly those intermediate risk patients. So the question is, should we focus more on trying to improve our ability to identify the patients that are in that intermediate high risk category that are going to shock and maybe will benefit from this escalation therapy, as opposed to actually subjecting many patients that we don't really know if they're going to deteriorate or not to some of these interventions that may have including morbidity and mortality.
So yes, absolutely. Again, if you haven't figured it out, my tone is a much more conservative approach than perhaps I'm demonstrating here. The question is, how do we identify the highest risk cohorts? And you can either do it through prospective randomized trials, or you can do it through observational registries. The National PERT organization, which David alluded to before, we've already captured encounters with over 3,000 patients across the country with 50 sites. And one of the first sort of data dumps and data analyses is to try and look at vital signs of presentation, biomarkers, laboratory profiles, findings on echocardiography, and then correlating that with mortality, clinical deterioration, and looking for any kind of patterns. From my point of view, there's a huge opportunity for AI to try and tackle this and navigate this and come up with an equation. We all struggle with PESI scores and Miller indexes, and there's a litany of different things. I don't think it necessarily needs to be that complicated, honestly. I think that there's probably a way to do this either through an app or some AI program that's superimposed within Epic that will be able to say, based on Mount Sinai's experience, this patient has a 10% mortality rate in 30 days because the last 500 patients that you guys treated, this demographic didn't do well. And I think that's how in the future we're going to make these decisions. But unless we're recording the data in a homogeneous, uniform, almost case report form methodology, we're just always going to be sort of struggling with what the patient looks like at the bedside and sort of going with our gut. So again, I'm a big believer in data to try and drive our decisions, which is why I'm not a liberal adopter of this stuff, because I don't think there's enough data yet. But I firmly believe we should be doing prospective research. I think we should be recording all of our cases in prospective registries so that big data analytics can give us some kind of guidance on who we should be much more relaxed on and comfortable watching, and who we should be much more aggressive and trying to rescue. But it's an excellent point.
I just have a corollary comment.
Yeah, sure.
Thank you for a great talk. And it's really been important for us to bring PERT to our two hospitals. But the thought I've had as you've been talking, and it sort of relates. One, I did get to thinking, is there a role for AI? But also just imagining these conversations you're having late at night. And behavioral psychologists will tell us about, and there's various matrices for looking at decision making in circumstances where there's a certain degree of pressure and intensity. And I just feel like there may be some opportunity too to look at how, and I think it's probably true for the stroke team as well and other places, look at over time, how those decisions are rendered and what we can learn about how we interact with each other and how we kind of get to decisions around these really complicated cases with so many variables and so much unknown, as you've been so good about talking about.
Sure. No, I think AI is going to have a huge role moving forward, and I also struggle with how do you get a team to mobilize at 3 a.m. and what the different dynamics are at 3 in the afternoon, just as an example.
Yeah.
And I think we would agree the tone of the conversations are very different at 3 in the morning than they are at 3 in the afternoon. I wish I had a solution for that right now, but I think that if we are able to share our data amongst ourselves and record it uniformly, I think there's huge opportunities to learn from our own experiences and have it not be as subjective. It won't happen tomorrow, but I think in the mid to midterm future, perhaps we'll be able to have enough of an experience. We'll be able to say, like, with 1,000 patients clearly told us that this is where we should have clear consensus. This isn't an opportunity for subjective interpretation, because we've learned now that this will happen to this patient with a very, very high confidence.
Thank you very much.
Sure, thank you.